Good evening, everyone. I hope I can speak. Otherwise, you guys have to probably read the slides. So the first one, patient is a 64-year-old female with ischemic cardiomyopathy, severely depressed EF of 20% despite being on guideline-directed medical therapy. She is also on home milrinone therapy. She has chronic left bundle branch block with a QRS duration of about 160 milliseconds and NYHA class 4 symptoms. She's being evaluated for advanced heart failure therapies like LVAD and heart transplantation. She was referred for BIV-ICD implant. So this was her baseline ECG. You can see normal sinus rhythm with typical looking left bundle branch block, as we discussed this morning. It has notches in the contiguous leads, 1, AVL, V5, V6, there are no Q waves. So as you can see, we got the A and the V leads in. This is the CS venogram. Doesn't look as juicy as what Dr. Sharma showed us this morning. But we were planning, it does have some posterolateral branches, but they look like there's some proximal stenosis. As you can see in this clip, we got the wire through this posterolateral branch all the way down into the MCV and back into the CS. So we had good support, but despite using outers, inners, 5 French wort, we were not able to advance the lead. As you can see, as we are trying to advance the lead, everything gets pushed back. I think it's because of the proximal stenosis. So at this point, we had a couple of choices. We were already like a couple of hours into the case. This lady is very sick. She's on milrinone therapy. Yeah. So this is the wire you can see. So the one thing which we were thinking was we can change the entire system into a Worley system, and you can snare this and try to get the CS lead all the way down. That was one option, snaring. The other option is to implant a conduction system pacing lead. So we decided to go with the conduction system pacing lead. We got a good HES. We were able to selectively capture but could not correct the left bundle branch block. At that point, we decided to attempt a left bundle branch area pacing lead. Yeah, you can dilate it, you can snare it, you can do a lot of things. But she was already like 2 hours into the procedure.
For balloon dilatation and entering into the selectively through the slack sheath, subslack sheath into the across the stenosis.
You can dilate those. Yeah. So, but anyways, we went for a left bundle branch area pacing leads. As you can see, we were not prepared. We had only 6 leads. First side, we paced. You can see AVR, AVL discordance, lead 2, lead 3, and we had a nice notch. The initial QRS duration was about 150 milliseconds. It just took 4 to 6 turns. After 6 turns, we had a QRS duration of 122 milliseconds. We already had a RSR prime pattern. This literally took less than 5 minutes. We exchanged it to the CS fixed curve sheath, went in, initial side, 4 turns, and we had this. And possible retrograde left bundle potential. So this was a septogram. You can see the lead tip at least 1.4, 1.5 centimeter deep into the septum. This was a transthoracic echo. You can see the lead coming all the way up to the LV subendocardial region. So these are some of the rhythm strips. So once in a patient with left bundle branch block, as we did in the 2 cases this morning, once you get this QR or RSR prime pattern, I think that's a good result, because then you can play around with the AV delays and see which is the sweet spot. So in this case, when you shorten the AV delay significantly, you're force spacing the left bundle, so you get an RSR prime pattern. So when you stretch out the AV delays to 60 and 80 milliseconds, Now, what you're trying to do is you're trying to let the impulse come down to the sinus node, get into the right bundle, and once it's in the right bundle, you pace the left bundle, so that now you're activating both right and left bundles and activating the ventricles at the same time. As you go extend the AV delays, you'll start to get more of, it starts to get widened actually. So this was the final ECG. QRS duration was pretty good. Next morning we stopped her milrinone. She felt good. This was the chest X-ray. You can see the left bundle leads. Here. So no procedural related complications were observed. She was weaned off her home milrinone. We did an echocardiogram 2 months later. Her EF was about 15 to 20% on milrinone. Off milrinone, her EF improved to 30 to 35%. Her symptoms improved, and she has not had any heart failure hospitalizations in the last 5 months. So I thought this was a fascinating case to show both echo and clinical response with left bundle branch area pacing. Let's move on to case 2. 63-year-old female with intermittent chest pain, especially when she exercises, ongoing for the past 4 to 5 years. She had extensive cardiac work, which included normal echocardiograms. She had a cath, which was normal. She had a cardiac MRI, which was normal. Didn't show any delayed gadolinium enhancement. Over the years, it was attributed to microvascular disease, and she was put on high-dose calcium channel blockers. She didn't tolerate beta blockade very well. All this workup was like over the past 2 years. She continues to have chest pain despite being beta blockade. So she was referred for a stress echocardiogram. So this is the baseline ECG just before starting the stress echocardiogram. Patient is symptom-free. As they were about to start exercise her, she started complaining of chest pain. ECG obtained when she complained of chest pain showed this. Just with small increase in heart rates from 50s to 60s, she got left bundle branch block. So what's the diagnosis? Any takers? Yeah. So there is a rare entity called painful left bundle branch syndrome. Again, the exact hypothesis is not known, but the most plausible explanation is that patients with this, they are very sensitive to ventricular dyssynchrony, which may cause chest pain. And until then, I was very skeptical, but this case actually is an eye-opener. I've been following her for almost 11 months. So once we diagnosed the painful left bundle branch syndrome, we decided to implant a conduction system pacing lead. If you look at the literature, in the past, people have used bi-IV pacing to treat this. There are very few cases of his bundle pacing for painful left bundle branch syndrome. There are actually 3 cases. 2 of the cases have thresholds more than 2.5 at 1 milliseconds to get a non-selective his bundle. And when one of the cases actually is from UPenn, patient came back with chest pain because his threshold started creeping up. Yeah. And I think there's one case from Mayo Clinic, the thresholds were stable, but again, that was a short-term follow-up. So in this case, we decided to do left bundle branch area pacing lead. So this is our baseline ECG. Again, we got a nice left bundle branch area pacing lead. And at that position, you can see a nice retrograde potential, which was like about 40 to 50 milliseconds from the surface QRS. And then by adjusting the AV delays, again, trying from 250 to 150 to 180, you can see at this point, when the AV delay is short, you can see RSR prime pattern. When the AV delay was at 180 milliseconds, it was pretty narrow. So this was our final ECG, completely normalizing the QRS. We actually were a little skeptical. So what we did next day was we tested her, like blinded her to the pacing. Whenever we come off pacing, within a few seconds she said, I'm having chest pain. We don't even tell her. We come on pacing, chest pain goes away. So we send her home, A week later, she works in a doctor's office. So every time she gets chest pain, she goes to the doctor's office, gets an ECG. This is one patient where I gave my cell phone number. Actually, I don't do that. So 1 week later, she said, I'm having chest pain again. I was scared because this was like in the beginning, like when we started doing left bundle branch area pacing leads. I'm like, oh, maybe the lead dislodged. I said, why don't you get an ECG and send it to me? And she sent it to me, and it's left bundle branch. Normal sinus with left bundle branch. I don't see any pacing. I'm like, maybe the lead dislodged. When she came back, what we found was her PR, intrinsic PR, is very short. It was beating the set AV delays, so she was having intrinsic conduction, left bundle branch, and then she was having pain. So we had to adjust the AV delays. We used rate adaptive. We made her walk in the hallways, try to get her heart rate up. So we finally were able to find the sweet spot, and she has done extremely well over the last 11 months. We actually had second case of painful left bundle branch syndrome, and we actually put both of them together and accepted for publication in JACC case reports. This is the last case. This is for Parikh. So this patient is in her 60s, got a his bundle pacing lead, okay? Develops exit block 6 months later. She was referred for a left bundle branch area pacing lead. So we let the his bundle lead at that location. So you can see A, H, and V. We got the left bundle branch area pacing lead, and we had a left bundle potential. And you can see the potential to V was 22 milliseconds. So this was his bundle pacing morphology. So what were her thresholds at implant? So at implant, her threshold was 0.7 at 1. You would take this any day. At 1 month follow-up, it was 0.5. At 6 months, it was 4 at 1 milliseconds. At 8 months, it was 4.5 at 1 milliseconds. So this is something which we cannot predict. So why did the thresholds go up at 6 months all of a sudden? So this, I think, is one of the biggest things for the his bundle leads. How do we predict this delayed rise in thresholds? So she got a left bundle branch area pacing leads, and you can see the QRS looks not perfect as his bundle, but it still looks pretty good, less than 120 milliseconds. And it's been like 5-6 months, her thresholds have been stable, she's doing well. So what we did in this case was, now that we had a his bundle lead and a left bundle branch area pacing lead, you had a his potential and a left bundle potential. One of the way you demonstrate direct left bundle branch capture, this morning I showed retrograde VA times with unipolar tip and ring. You can do the same thing, V to his timing, retrograde, with ring and tip pacing. So here, we are pacing the left bundle ring in a unipolar fashion, unipolar ring pacing. And you can see the retrograde his, because it has to come all the way down and then go up. And when we pace the unipolar tip, since it's in the conduction system, it goes up to the his faster, and the retrograde his time will be shorter. That's again one way to demonstrate you are in the conduction system. I think that's it.